All right, good morning, everybody. My name is Aron Pollack. I'm not a neurosurgeon. I'm actually an ENT or an otolaryngologist. We do a variety of things. It's definitely a surgical field and a medical field. Depending on what your interest is in, you focus on one, former or the latter, more or less. My training was in endoscopic skull base, so essentially we can address lesions which involve the skull base that can be accessed endoscopically, namely with cameras through the nose. And that can involve the anterior cranial fossa, the middle cranial fossa, or even the posterior, meaning the front, middle, or back part of the base of the skull. That's the floor. And an interface is immediately below the floor of the brain, really, are the paranasal sinuses. The sinuses that we all talk about in a day-to-day life: sinus infection, sinus headache, allergies, so on and so forth. So even though this is really at its heart, a neurosurgical course, I do want to say that there is a room for otolaryngology, which is ENT. So the title of my talk will be focused on particular lesions, not very common, but we see them enough, where you have essentially either brain fluid leaks through the nose, or you have little knuckles of either brain lining or brain tissue and lining that herniate through this floor of the brain into the sinuses. And the simple presence of brain tissue or brain lining, which is within that is brain fluid, in the nose places patients at much higher risk of developing infection because, well, the nose has normal bacteria in their microenvironment, and that's normal, but the brain doesn't. And so when you have this anomalous connection and you're leaking fluid one way, there's always a highway the other way as well. So meningitis is certainly a much higher risk. So I'm going to talk about how you approach these certain lesions, whether if it's just leaking brain fluid or leaking fluid from the presence of a meningocele, that's a cystic-filled space lined with brain tissue in the nose, or an encephalocele, which is the cystic space with also brain tissue in the nose, how you remove them, how you fix the hole, and how you ensure that it doesn't happen again. There are 4 questions you have to ask when patients present with a history suspicious for leaking something like brain fluid through the nose. Well, brain fluid, I'm sure you all know, it's clear. It can taste even sweet. It has high glucose content. Sometimes patients say, "Doc, I've been having constant clear drainage from one side of my nose for however long a period of time." Other times they can present with meningitis without even knowing they were leaking. Other times you can find things randomly or incidentally on a scan for something completely different. But the most important thing is understanding the anatomy. And I guess as aspiring doctors, anatomy is really the basis of everything. Knowing normal anatomy can make you appreciate abnormal anatomy. And so in so doing, you have to know where the leak is coming from. And in doing that, if it's coming from the nose, you have to understand the anatomy of the nose. And there are essentially 4 bones I'm going to show on a variety of scans and images that make up, I guess, the roof of the sinuses and the base of the skull, or the floor of the brain. These are 2 representative images of, it's a CAT scan. Scans are very easy to read. There are essentially 3 colors. There's black, there's white, and there's everything in between. Black is air, and white is bone, and gray is soft tissue. This is the nose of a patient, the lips. This is called a sagittal cut. It's the side of a patient. Here's your spinal cord. The black is air. That's your airway. This is your tongue over here, your lower teeth, and your upper teeth. This black area is air, and that's your frontal sinus. That's the air inside your frontal bone. So your brain is here, your sinus is here, and this is just the outside area, your scalp, obviously. So this is your frontal bone, or the back wall of your frontal sinus, called the posterior table. As you go further back, you have, and this is your frontal sinus highlighted in the red. You go a bit further back in the green, that's your ethmoid sinuses. That's the ethmoid roof. Your sinuses are little labyrinths of air and bone below this skull base. That's your ethmoid sinuses. That's your frontal sinus. This is called the cribriform plate. That's a very specialized area of the skull base, which allow you to process smell. And as you go further back, this is your sphenoid sinus, or your sphenoid roof. This is your sella, in Turkish for saddle. This is where your pituitary gland sits. A very frequent procedure I do with the neurosurgeons is removing pituitary tumors. It's a very quick and simple access going through the nostril to get to the pituitary, as opposed to making a big incision through the scalp and coming from above. It's really revolutionized pituitary surgery. And you also have back here is in the red, your clivus, which is the occipital bone. Your frontal and your ethmoid or anterior cranial fossa. Your sphenoid is your middle cranial fossa, and your clivus is your posterior cranial fossa. Now, looking at a patient in a different view of the CAT scan, this is a coronal image. Again, the patient's looking at me and I'm looking at them. This is the right eyeball, this is the left eyeball. This is your brain up here, and this is the base of your frontal sinus, and these are large frontal sinuses here. You have to know the limitations of the endoscopic approach, namely how you can access the skull base through the nose. And you really can't go further endoscopically beyond the mid portion, the mid-pupillary line. Anything beyond here, lateral to here, to the side of here, can only be accessed through an incision transcranially through the scalp, or through the face, or through both. It usually cannot solely be accessed through the nose. As we go further with a coronal view, we now start seeing more anatomy of the sinuses and also of the overlying brain. This white line is the base of your skull. That's your skull base, okay? I want to focus on the fact that this is really focusing on anatomy. You have to know the different anatomical variants of normal anatomy. Now, this is your ethmoid skull base, and these are your ethmoid sinuses, little bony partitions filled with air, which is black. This patient has normal sinuses. There's no soft tissue. They're not gray. Here's a normal eyeball. This is a cheek sinus. This is your nasal septum, which is deviated towards the left. These are turbinates. But enough of the ENT anatomy. This is the base of your skull. And your ethmoid is almost like a stair-step fashion. You have thicker white bone here. It's the fovea, the roof of your ethmoid. You have thinner bone called the lateral lamella of your ethmoid, and you have even thinner, more lower bone. That's the cribriform plate, this tiny little strip, 2 millimeters wide. Again, that's where you smell. It's not in the sinuses. You breathe through the floor of your nose, but you smell through the roof. But in the same patient, you can have very different sloped ethmoid skull base anatomy. Whereas your fovea is much higher here, it drops down steeply to a much lower cribriform plate. When people are doing sinus surgery, it's safe to be right here, but millimeters away, that's not safe because that's brain. Sinus, brain, good, no good. You get into this, you create a hole, you have to fix it, and it's not good. I mean, it's fixable, but the patient won't be that happy. As I go further back from the ethmoids, the next sinus is your sphenoid sinus. Now, your sphenoid is really the gateway to your endoscopic skull base. There are so many important structures around your sphenoid sinus, and these two pictures of two different scans illustrate the different shapes and sizes of the sphenoid, which is important to know, and also the different important structures. Now, this is the back wall of your nose. That's your soft palate's going to be immediately under here, and this is just air in the back of your nose. That's essentially where they do a swab to get you COVID tested. It's like 7 centimeters in. It is painful and it sucks, but that's where they're going to go. But here's your sphenoid sinus. This little area here is your carotid artery. Sometimes you can have a little dehiscent wall. Getting into that means significant hemorrhage, life-threatening. The optic nerve, the nerve that gives you vision, sits up here. And you have two bony structures, bony circles within essentially bony canals. It's this hard bone here, air, brain, bone. This is called V2, the second division of your trigeminal nerve. It's purely sensory, and it gives sensation to your cheek, to your sidewall, your nose, to your upper lip. It's purely sensory. And this over here is something called the pterygoid canal, or the Vidian nerve. That's what we call parasympathetic fibers. That allows you to lacrimate. That gives your nose moisture and mucus. Cutting this gives you a dry nose. Cutting this gives you a numb face. Totally different. Now, the same structures, whereas on the left are encased in thick bone and very close, these structures here are much further apart, simply because this patient on the right happened to have a much larger sphenoid sinus. And this bone is not hollow, it's solid. This bone has air completely in it. Here's your V2 here and your Vidian, V2 and Vidian, but here V2 and Vidian are very close. It's important to know this because of this space right here. This is called the lateral recess of your sphenoid sinus. Lateral means all the way to the side. Medial is towards the center, lateral is away towards the side. This is often a site of spontaneous leakage of CSF through patients' noses. This patient does not have a lateral recess. This patient does. Important to know normal anatomic variants. Now that we've gone over the basic endoscopic, by endoscopic I mean something done with cameras, endonasal through the nose, endoscopic, endonasal, skull base, the anatomy. Now the next step you have to ask yourself is, now if this patient is leaking fluid, I have to repair it. I know where it's coming from. How am I going to repair the hole? So the first thing you have to ask is, well, size doesn't matter. How big is it? A very small hole probably doesn't need that much of a hardy or robust repair, meaning less tissue, less layers. It's probably easier to fix. So you have to know dimensions. And the third thing you have to ask yourself is, why is this patient leaking? Now, the obvious thing can be, well, maybe there was recent trauma, and that's what we call iatrogenic. That was caused by something. Someone had sinus surgery, inadvertently they damaged the skull base. Again, these are millimeters, but millimeters really translates into surgical miles. They were somewhere they shouldn't have been. So you can have maybe a surgical unplanned or planned trauma, or you can get into a motor vehicle accident and have multiple skull fractures involving the cranial base. These are all common causes of brain fluid leakages through the nose, but that's all due to an inciting factor. The second class of brain fluid leaks through the nose, which I really want to focus on here because they're quite interesting, are something called spontaneous CSF leak. I have one to repair tomorrow. I had one 2 weeks ago I did with Dr. Bookvar. These are patients who, for whatever reason, start leaking brain fluid from their nose after having absolutely no trauma nor instrumentation to the nose via surgery or tumor removal or really anything. And the reason these people develop it, even though it's poorly understood physiology, boils down to having what we call intracranial hypertension, which is a neurosurgical term, or pseudotumor, meaning the pressure around their brain is very high. When people operate on the brain, I'm not a neurosurgeon, but I've seen videos, I've seen my colleagues operate, the brain pulses, it pulses like the heart, it pulses. And years of constant beating against the base of the skull, the floor, wears away at this bone. And it almost becomes like Swiss cheese, so to speak. And over time, holes develop, and then the lining of the brain may herniate through the hole, and then brain tissue may herniate along with the lining. And then over time, they start leaking fluid. Now that's really the most basic understood physiology or pathophysiology behind this, which is why the demographics for patients who present like this are typically not young, because it takes a long time to develop these. They're not embryonic, they're not congenital. They're in their 40s or 50s. They tend to be fat, simply because people who have higher BMIs tend to have higher intracranial pressure, and they also tend to be female. So fat, 40s, 50s, female. 3 Fs are really your high yield board answer. And knowing if someone has intracranial hypertension, there are certain radiographic findings that we're going to highlight on certain cases I'm going to have after going over the anatomy. And there are certain things you can see on MRI imaging that seem to depict a picture of intracranial hypertension. Not everyone who has intracranial hypertension is going to be leaking brain fluid through the nose, but people who leak brain fluid through the nose spontaneously tend to have intracranial hypertension. The last question you have to ask before attempting repair or fixing of this hole causing the leakage of the brain fluid is there any pertinent medical or surgical history? Now, these are important both for wound healing. A diabetic that's poorly controlled will never heal as well as someone who's non-diabetic. Someone whose thyroid is out of whack will also never heal as well as someone who is what we call euthyroid, or normally a normothyroid. People with prior endoscopic surgery where things have been removed, things have been cut, there have been scarring, limit how you can repair things, because tissue that has its own blood flow that can be moved around almost like a flap, maintaining its natural blood flow will always heal better than just putting up a patch of tissue to close a hole. A patch is okay, but it's dead tissue. So if you really need it to hold and then regrow live tissue around that dead tissue, it's not going to be a great option for reconstruction of this hole, allowing the brain fluid to leak. So prior surgery, prior radiation therapy, all of this limits your reconstructive options, both in quality and quantity. Radiated tissue, qualitatively, is not nearly as good as non-radiated tissue. And lastly, if there's tumor in the nose, if there's cancer in the nose, you obviously can't use that tissue to reconstruct because you got to remove the tumor before you reconstruct. Lastly, the principles of repairing these holes in the skull base or the roof of the sinus cavity really is predicated on two things. You have to expose the hole really well, 360-degree around the hole, and you have to repair it with typically more than one layer. I like to do 2 layers. We put a synthetic Duragen matrix above the base of the skull, whether it's an epidural or subdural layer. And then we also use what we call an onlay. This is typically a nasal tissue, nasal mucosa that is in the sinus cavity. So an inlay and an onlay. That being said, now that we've reviewed the anatomy and we've reviewed the etiology behind these CSF leaks, and we reviewed the very basic and fundamental principles of repair, now I want to highlight various pathologies of CSF leaks through the nose involving all areas of the skull base that we initially discussed at the start of this lecture, namely the frontal, the ethmoid, and the sphenoid, different parts of the ethmoid, because where it is will also depend on how you reconstruct it. So that being said, we'll start with the first case. This is a lady who is always told she has quote unquote sinus headaches, and she always pointed to an area above her right eye. She didn't have green discharge. She had no issues with sense of smell. She could breathe out of her nose. She really didn't fit the bill for someone who really has sinus problems. And I get a CAT scan for her, and the first thing I see is this. Now, as I said, white is bone, black is air, and gray is everything in between. This is brain over here. This over here is the frontoethmoid, the junction of the frontal and the ethmoid bone, the frontoethmoid skull base. Whereas on this side, it seems to be above the orbit, you have noticeable asymmetry here. I don't really know what that means yet. Maybe the patient is crooked in the scanner. I don't know. And you see here this kind of soft tissue, which could be anything, could just be a polyp in the nose. I don't know what that means. So this raises an eyebrow, but I need more information. So I look at the same patient, but a different cut. And these are the sagittal cuts we first started with. And it's pretty interesting because anyone can see, here's the back wall of my frontal sinus. Nice, well-defined bone, but there's clearly a defect in this bone here. Anyone can see it. This is your frontal sinus, this is your ethmoid sinuses, and this is your sphenoid sinus. And I see there's no bone here, and there's a continuation of this gray brain tissue in through this into the nose. So something is not normal here. This is clearly either a meningocele, which is just brain lining with fluid, or a meningoencephalocele, which is brain and brain lining into the nose. So I get an MRI, because an MRI, and this is also looking again from above, clear defect in the anterior skull base. So I get an MRI. An MRI is excellent because an MRI shows soft tissue. And the neurosurgeons, I think, they always get MRIs. As an ENT, we like to get CAT scans first because when we want to image the sinuses, we don't necessarily need to see what the soft tissue is made of. Mucus, allergic stuff, infection, it's all the same to us. So we want to get a CAT scan to delineate bony landmarks. An MRI is very good for soft tissue. And I see here, this is a T1 weighted sequence on the left. This is a T2. A T2, the white sequence is water heavy, and that's CSF. It's water. This is in the brain, your ventricles. And here is some anomalous CSF with a thin stalk and some CSF-like signal, which is sitting in the frontal sinus. So without a doubt, this patient has some type of meningocele. Don't know how she got it. She was, I think she's, I said in her 60s, female, and she was very overweight. So she certainly fits the bill. And the same thing here in an MRI. That's a T1 weighted sequence, a T2 weighted sequence. So I want to illustrate how we repair this. So going on the CAT scan, if we want to expose this through the nose, we like to use both nostrils because having access through both nostrils allows two surgeons to operate simultaneously with four hands at the same time. Going through one nostril, it's a very small corridor, and you also have to see with the camera, it's quite difficult. So you want to get access through both sides. And the way to do that is I essentially have to remove the entire floor of the frontal sinus. And when I do that, I can now connect the right side and the left side together to triangulate this from both the right and the left side through the nostril. Again, they look the same on the outside. This is only surgery through the nose on the inside to get adequate surgical access to what's going on. So this is the nose. It's kind of tough to understand the anatomy simply because we're already in, but I'm going to explain to you here. I'm cauterizing. This is the olfactory cleft. That's the start of the cribriform plate. So already I'm not even in the ethmoids. Now I'm going to start to drill the entire floor of my frontal sinus. And we slowly drill. Now we start seeing our frontal sinus here. She has a very large frontal sinus. That back here is the posterior table. Now if I can pause it, and just rewind for a second. So over here is paused. Now this is looking through the entire back wall of the frontal sinus. This is the left frontal sinus. This nice thin mucosalized layer is the left frontal sinus. That's the right frontal sinus. And over here is going to be the area of this meningocele. And now, utilizing a two-surgeon, three-handed technique, we clearly see bony confines over here and some soft tissue emanating through that bone. Now, we're going to amputate this soft tissue, which is extending into the patient's nose. And now we see clear bony confines to a defect. There is a hole in the posterior table. Now we're going to smooth out these bony edges. And if you look very carefully at the next sequence, you'll see the area pulsing. As you see, that's pulsing because that's brain tissue. Now that we've prepared our wound bed 360 degrees and circumferentially, we're going to place our two-layered repair. This is Duragen. It's a synthetic dural matrix. I think it's made of collagen. And I like to tuck that in epidurally, meaning we give nice pieces of bone. Now, the second layer of repair is going to be the endonasal repair. This is actually fascia. It's connective tissue. This is from the leg. It's called Fascial Latae. It's actually really robust tissue. By the way, all these cases were done within the past 2 years at Lenox Hill. And this is tissue I harvested with an incision in the lateral thigh. We take off just, I guess, maybe like a 1 by 1 centimeter of tissue. We close it up. There's no functional defects. And we're going to tuck this in nicely in a gasket watertight fashion. So this is tucked nice and around our skull base defect. The propulsion of the brain behind it is not going to push it out. It's a nice gasket seal, and you see it quite well here. The mucosa is going to grow into this. Now, this is not a vascularized repair, meaning it doesn't have its own blood flow. So over time, the tissue will ingrow into this, and the two-layered repair should be robust enough that this will not recur and herniate through the bone. There are some people who like to reconstruct this with cartilage or bone, but there's no evidence, none, that it works better with good than easier soft tissue reconstruction. So this is a nice case of a CSF of a meningocele through a defect in the posterior table of the frontal sinus. Now the next case I want to highlight is another case, but again from a different location. This was a 65-year-old female. She was obese, a BMI of 48, who had right-sided clear rhinorrhea, clear nasal drainage for several months. Didn't have meningitis, but she just continued to leak. And she put her head down and she dripped from one side literally like a faucet. That's actually called a reservoir test. To show her imaging, we're beyond the frontal sinus. We're looking at the ethmoid sinuses. And we see here that on this side, there's clearly asymmetry relative to that side. This is the patient's right or the screen on the left. And we see that the bone in this ethmoid skull base is very thin, it's irregular and ratty. Can't say for sure if it's intact or not. It doesn't look intact. And then underneath that, there's just this soft tissue occupying the entire anterior ethmoid sinuses. This is the wall of my eyeball here, it looks okay. And comparing that to the other side, this is my fovea, which we discussed the roof of my ethmoids, the lateral lamella, and the cribiform here on the left looks normal, but here it looks pretty abnormal, and there's probably some missing bone here, and this is probably going to be brain tissue. I just don't know how much. Obviously, an MRI is going to be the next step. And we see an MRI here of the same patient. And hold on one second. And this is a T2 weighted sequence because CSF is bright. And I clearly see brain tissue going through a defect in the skull base here in the ethmoids into the ethmoid sinuses. This little rind of tissue here is swollen lining of the cheek sinus because CSF is actually quite inflammatory. So people with CSF leak also happen to have associated inflammatory disease of the sinuses. So this patient has a very large meningoencephalocele within the anterior ethmoid sinuses. And you see here the same thing, very large. Interestingly enough, just to look at her images, she has other signs that she has intracranial hypertension. This area here is called Meckel's Cave. Meckel's Cave is essentially an area, an intracranial area of the trigeminal nerves. That's the V1, V2, V3 that gives sensation. Again, that we spoke about the V2, gives sensation to the midface, sensation to the lower face, and also the upper face. They sit in a cistern of CSF, and this is quite expanded with CSF. So enlarged Meckel's Cave with CSF is an indicator of intracranial hypertension. This area is full of CSF above your pituitary gland called an empty sella. These are just signs that this patient has been, she's obese, has intracranial hypertension. Now, this is the endoscopic repair. Now, this is just looking in the patient's right nostril. Okay, I'm looking in the patient's right side. This is a normal structure called the middle turbinate. This is the nasal septum over here on the left. This is an abnormal structure. It may look like a sinus, but it's actually sinus lining, but below that is actually this huge encephalocele. Beneath this is brain. It's literally sitting in the patient's nose. So we have to remove it, open all the underlying sinuses, expose this hole in the skull base, and then repair it. And that's essentially, oops, hold on. And that's essentially what we did. So, and if you look closely, you can see it pulsating. I'll show that one more time because the brain pulsates. That pulses, but nothing else does. So we're going to first start, that's opening up the maxillary sinus. We're going to start by amputating the middle turbinate. Amputating the middle turbinate just gives us very good surgical access to the skull base. You need to do it to really expose things quite well, because as long as you expose it well, it's still minimally invasive. It's through the nose, but it just makes your surgery a whole lot easier. Now, this is a very important part of the case. I'm going to pause it right now. The way to reconstruct this hole, to put some tissue over that defect in the bone, you have to use hardy tissue that won't die, because as long as it has its own blood flow, it will ingrow into the surrounding tissue, and it's live. It makes life. It's revolutionized surgery like this. This is called the Nasopceptal Flap. You have a septum that's over here that separates the right and the left side of your nose. Okay? It's like a sandwich. There's cartilage, but there's also lining on either side of the cartilage. That lining has a big blood vessel that feeds it from the back of the nose. This is the back of the septum over here, and this artery is going to traverse this area right below your sphenoid sinus opening and supply the entire septum. So you're essentially going to elevate all this lining of your septum, expose the underlying cartilage, but don't amputate it here because that's its vascular supply. That's exactly where it's getting its blood flow from. It's a wonderful thing because removing it from the septum, leaving it attached here, allows a free range of mobility to the entire ethmoid skull base, sphenoid skull base, and beyond. Just a wonderful technique to have. So here I'm using a long needle tip cautery and I'm incising my septum. Now it's tough to see because most cuts can be done blindly. I'm taking the cut all the way to the front of the nose, and this is on the floor of the nose, and I'm elevating it off the underlying cartilage. And here is the flap. It's been elevated and it's stored in the back wall of the nose. Now that the flap is elevated, I'm going to start to define this large encephalocele. And as you see here, this is the entire knuckle of brain tissue herniating into the nose. That's the cut area of the middle turbinate. And this tissue is usually very big with a very small opening, a little neck. I'm going to amputate it at its neck just to open everything up. This is a bipolar instrument, and it's going to essentially burn this area. Now that it's burned, I'm going to start cutting. This is brain tissue over here. It's non-functional brain tissue. I'm cauterizing it. And usually during this part, you're going to start to see some clear fluid leak because it's over here. There's a leak in the skull base. And I'm going to continue to amputate this large encephalocele in the ethmoid sinuses. And once it's removed, we now have to expose the hole. I continue to cut and separate it from the overlying ethmoid skull base. And now I'm pulling it out of the nose. There's a wad of brain tissue. It's quite big. Pull out through the nose. And now I'm going to get my landmarks and expose the entire anterior skull base. So to give you anatomy, this is my posterior ethmoid skull base. It's intact. And this is my sphenoid sinus here. There's a little blood there and a lot of clear fluid continually leaking from the defect. Now I'm stripping the lining off the overlying skull base. That's the lining of the sinuses because I really have to expose things. I continue to strip it off because we want to graft our tissue to bone. And now that I've cleaned things up nicely, you clearly see a well-defined hole here. This is the roof of the ethmoids. And now we have scrubbed in with a two-surgeon technique, and we're going to start to separate the brain from the underlying skull base here. We start to see it quite well. All of this is brain tissue, and this is sinus. Now, before we put the DuraGen up there, I just want to show you what that looks like. So this is the entire skull base, okay, the ethmoid skull base. This is intact. This bone is super thin, but it's intact. This is clearly a hole, and this is non-functional brain tissue. We've amputated it at its attachment. The entire encephalocele has been removed. And now we're going to put a piece of DuraGen up in an epidural layer. This is going to be tucked in intracranially. As you can see here, we're trying to get it within the confines of that bone. And there's a second leak in here like we saw. Oftentimes people with intracranial hypertension have multiple leaks. And we're going to put that DuraGen in over here, and you see nice pulsation. This is really just dura. The bone is super, super thin. Now we have our two leaks. Now we're going to raise this flap. We're going to take this flap back that was stored in the back wall of the nose. It's still attached through its blood supply. It's really neat. And it's a big wad of tissue. And we've now flipped it up. As you can see, the entire flap is now all the way. It's still attached, but we've almost removed it from its normal septal attachment, and now it's literally lining the entire skull base, as you can see here. That's all flap. And we have beautiful vascularized coverage, and you see nice transmitted pulsations. Our sphenoid sinus is open, it's back here. And it's a really wonderful repair to an otherwise difficult problem. And now this normal nasal tissue regrows. That's our sphenoid sinus. And this patient did well. Again, this is intracranial hypertensive, multiple anterior skull base defects, very large septal flap attached at its normal site. So this tissue is all alive. It's bleeding. It's wonderful. The next case was a 56-year-old female who had 2 episodes of bacterial meningitis in the setting of left-sided clear rhinorrhea, clear nasal drainage for several months. Looking at a coronal scan here, we see some asymmetric gray tissue here. Now, the last patient had a defect over here in the roof of the ethmoids. This patient has a defect in what we call the cribriform plate. We've mentioned this several times. This is where they smell. This is the most common location for people to have spontaneous CSF leak, the cribriform. It's very thin bone. It's the lowest area of the anterior skull base. This patient has a very low cribriform. It's literally at below the mid portion of her eye. And so you see here, it's very small. It's almost like the brain is pumping fluid through an incredibly small opening, but you clearly see asymmetry in the left cribriform relative to the right. And that is pretty much where she was leaking from. This is the same patient with a T2 weighted MRI, and we use T2 because CSF is bright, and we see the same CSF sequence in the nose as we do above over here. It's important to note that we discussed radiographic findings of people who have high intracranial pressure. This patient has 2 of them. On the left, you see scalloping or pitting of the middle fossa floor. This is seen in many patients who have high intracranial pressure. Just the constant beating of the temporal lobe over the underlying middle fossa floor causes scalloping. And there's also, we mentioned something called an empty sella. Now, this is the patient's sphenoid sinus over here. This little pancake thing is actually her flattened pituitary gland. Years of constant beating pressure have weared down on this pituitary, and the sella is actually filled with CSF. And your pituitary gland is a fat, tiny, flat pancake. This is your pituitary stalk that goes up here in your optic nerves. So again, empty sella, middle fossa scalloping, signs that this patient has intracranial hypertension. So in terms of repairing this defect, it's again similar principles. We've already done a bit of sinus work here. Now I'm going to start to raise my nasoseptal flap. This is what we call the rostrum of your sphenoid sinus. This is the natural opening to my sphenoid over here. It's not been enlarged. This houses something called the posterior septal artery. This artery runs in this tissue and it's going to supply the entire nasal septum. So I want to harvest that like we did in the other patient. So I'm going to make 2 cuts, one above the opening of the nose, and I'm going to take this onto the septum. Your septal flap does not need to be huge. It only needs to be big enough to cover your hole. Because remember, exposing cartilage in the nose will necessitate a long period of wound healing to regrow tissue. I'm going to make a cut above here as well. And I'm going to connect it to now I'm going to raise the septal mucosa overlying the cartilage. And that's going to be my septal flap to reconstruct as the onlay layer. Here's my sphenoid sinus opening. And now I'm going to start to look for the defect of the skull base. This is my fovea. That's the roof of my ethmoid over here. That looks intact. This is the cribriform plate. I'm going to cauterize, try to expose. Here is a curved suction. And we can start to see perhaps some CSF leaking, some pulsing over here. Typically, it presents itself right there. So you clearly see something leaking over here, and this is the site of her spontaneous CSF leak. So now we're scrubbed in with neurosurgery. Once I expose the defect, they're going to try to prepare the wound bed a bit more. We see the dura of your cribriform and a little rent in the dura over here, and that's clearly our site of leak. So he's going to prepare the area and also making it bigger. At the same time, cauterizing the mucosa. You see the pulsations of the overlying dura here. And then once we're ready for grafting, the same principles. We have the inlay duragen, which is going to be stuffed in as an epidural layer. Pretty big piece. That's not nearly enough because this is not vascularized. Then we're going to take our modified, it's a much smaller septal flap that we raised. We tucked it down into the nasopharynx, and we're going to flip it up, maintaining its blood flow to give nice closure of that hole. You see it's flipped up here. It was here, and we flip it up. It's a nice, here's our sphenoid sinus. It's open. Try to relieve the tension. And it's a nice watertight closure. We put some absorbable packing in, and this patient did quite well. So we've already seen now a defect in the frontal bone. We've seen 2 separate defects in 2 areas of the ethmoid bone. And now we'll continue with a 4th case, highlighting very similar concepts but different anatomy. This is a very unusual case of a patient, a 36-year-old female, maybe a little bit overweight with right-sided clear rhinorrhea for 1 month. And we're looking here at your sphenoid sinus, and there's clear bony dehiscence in the roof of the sphenoid. Not a very usual location for CSF leak, very strange. See, the bone is a bit thicker. The underlying sphenoid sinus is opacified, meaning there's stuff in there. It's probably CSF and brain, whereas the other sphenoid sinus is normal. This is an MRI, which really highlights a knuckle of brain tissue sitting in the sinus. And this is probably just inflammatory stuff. It's not CSF, but you do have at least a meningoencephalocele sitting through this defect, this hole in the sphenoid roof, the planum, normal left sphenoid and abnormal right sphenoid. So this certainly should be repaired. And again, the same patient looking at a sagittal view in a T1 weighted contrast enhanced scan. This is actually your sella here. And this is your pituitary gland. This dark is your CSF because it's a T1 image. And this is your sphenoid sinus here. Here is your meningoencephalocele here, and this is the underlying inflamed mucosa and mucus within the diseased right sphenoid sinus. Again, a strange location for CSF leak. Now this, we already did most of the bony work. This is, again, this is the right sphenoid sinus. We're raising a nasoseptal flap on the right side that we're gonna, again, flip not forward like the other cases, but actually back on itself. We're making our cuts on the septum, our superior cut on the septum. Our anterior cut. It's a short flap because you don't really need much reach. We're going to elevate it off the septal mucosa. And we're going to store it in the nasopharynx. And now we're going to expose this entire skull base defect. So this is my left sphenoid, and this is my right sphenoid. This is very pale, boggy lining. It's inflamed. We knew that on the MRI. And my defect is somewhere here. So with the two-handed technique, we see the brain tissue here. We see the inflamed sphenoid lining around it. Here's our sphenoid wall. And we're going to expose the skull base defect. Remove some brain tissue. Cauterize the knuckle of brain and shrink it intracranially. Now we're using a high-speed drill. We're going to drill off these bony septations, create a nice, smooth grafting surface. And we see here quite nicely 360 degrees of bone, the knuckle of shrunken brain tissue here. We're stripping the sphenoid lining because you can't put mucosa over mucosa. We're going to cauterize this a bit more intracranially. We're going to cut it. Now we see it quite well. I'm going to thin out these bony edges a bit better. Now that we've really prepared the wound bed, we're going to put some Duragen in. We're going to bring our flap up that we raised that was stored in the nasopharynx. And not every flap has to be big. And we're going to flip it up on itself and cover that hole. This flap is a wonderful flap, very versatile, can really reach most areas of the endoscopic skull base. The first case, we couldn't use it because it cannot reach up into the frontal sinus. Here we have a nice flap. It's tucked over and on itself with nice closure of that right sphenoid roof defect. This is also a very interesting case. This may be the last case of a 60-year-old female who had 2 separate episodes of bacterial meningitis with intermittent left-sided clear rhinorrhea. It was, I guess, never known that that was the source of her meningitis until she finally came in with another episode of meningitis. And what's interesting in this patient is I showed you in the beginning of the lecture a comparison between 2 different sphenoid sinuses, a very small sphenoid sinus and also a very large pneumatized sphenoid. Now this patient, this is a CT with contrast because you see her carotid arteries light up. This patient has, here's your V2, she has large sphenoid sinuses. Now this left sphenoid, you clearly see a hole right here. Your V2 is here, so this is actually a defect in what we had already spoken about, the lateral recess of your sphenoid sinus. Now the cribriform plate is the most common location for a spontaneous CSF leak, but the lateral recess is actually the second most common location for a spontaneous CSF leak. So whatever's going on with her, she has a skull base defect in the lateral recess of the left sphenoid sinus, right here, and also on the axial cut over here. And she has an underlying completely opacified or sphenoid full of probably inflamed mucosa, some mucus, and the combination of the 2. Now this is, again, we already did a lot of surgery so far, but I just want to highlight the anatomy because it's a little bit difficult to discern. Oops, I'm sorry. Let me pause it here. Hold on. Irrigating a lot. Sorry, guys. So this little ridge is actually your V2. This is the canal where your maxillary division of your trigeminal nerve is sitting. That gives you sensation to the face. And everything of interest is going to be beyond lateral in this little crack over here. You're going to see a little nervous structure that runs over here. That's your Vidian nerve. We had discussed both of them. When this area has air in it, this goes up and out, that goes down and in, and you create this space called a lateral recess. In patients who don't have it pneumatized, they just have a contracted sphenoid, and these 2 are in the same bone. But when they're pneumatized, they extend further beyond, you create a lateral recess, and that's really the area where she's leaking from. This is all within the sphenoid. We've already done a lot of sinus surgery to open this up. And we're mostly looking at an angle here, 45-degree angle to expose. And you start to see there's the hole right here. We've already done a bit of work in terms of exposing the defect. And you can see clearly your Vidian nerve over here, your V2, and your skull base defect. This area here, just for anatomy, is actually the back wall of the cheek sinus, okay? This space here is a very important structure, I guess as an ENT. It's a fancy space called the pterygopalatine space. That is beyond the back wall of the cheek sinus, and it's immediately in front of the lateral recess of the sphenoid. It houses a lot of important nerves and structures. It's also a highway in the face, really to many different places. It connects superiorly up here to the eyeball through the infraorbital fissure. It connects inferiorly to the mouth through the greater palatine foramen, connects into the nose through the sphenopalatine foramen, where the big vessel you have to cauterize. This is the vessel that supplies the Nasoptal Flap. So because we have to cut that vessel to get access over here, the septal flap we used in the other cases I highlighted is not an available reconstructive option for a leak in this particular location. So again, important to know anatomy and limitations of reconstruction. Now we're looking with an angled scope, and you can see V2, Vidian, defect. So we're going to tuck in, again, a piece of Duragen, and we'll tuck it in as it's really a crude inlay. And this is not a vascularized flap, because again, we said the flap is not an option here. This is actually just a mucosal graft. When we remove areas of the nose, we can actually harvest mucosa overlying it and then save it in the back table in the OR and kind of line this area and then pack it. So hopefully this as a free graft will take. It's not as robust, and we're going to put some absorbable packing around it so it stays in place. And it makes it look nice and pretty until it heals. Again, post-operatively, this is just a bunch of neurosurgical packing. Post-operatively, it takes a long time to heal, and there's a lot of inflammation, there's a lot of wound healing and time. But certainly after a month, you really can start to see your repair. And if obviously anything goes wrong, that will present itself within the next week or so. If they continue to leak CSF, if they continue to have meningitis, your flap potentially could necrose or die. These things happen, unfortunately, not commonly, but they do. And we have to know how to deal with them should they arise. After you've repaired the defect, you know where it is, you understand why it happened, and you deal with it. The next step is understanding, well, why did it happen? So if the pressure is high around the brain, just corking the bottle may not give you a definitive repair, because even if you repair it really well in that place, if their pressure is still high in their brain, they still have intracranial hypertension, they could leak from elsewhere. So a diversion through either a temporary lumbar drain or an EVD that the neurosurgeons place, or formalizing that into a VP shunt, a ventriculoperitoneal shunt, to constantly divert the CSF, that may be in these patients' futures to prevent this from happening again and to ensure good endoscopic repair of that hole. I always give antibiotics routinely that particularly cross the blood-brain barrier. I like third-generation cephalosporin, ceftriaxone. In my training was always used. When there's a penicillin allergy, we use vancomycin aztreonam. I always put non-absorbable packing. By that I mean almost like an inflatable tampon we put in the nose. I usually leave it 5 days, and then I take it out. There's a lot of layers of absorbable packing you saw in the last video over the repair, but even below that absorbable packing, I leave the non-absorbable to keep it wedged in place, and that stays in no less than 5 days. And nasal precautions, I don't want the patient to blow their nose hard. If they're going to sneeze, they sneeze with their mouth open, don't want to bend over, so on and so forth. I think that is probably it with the lecture. I hope that you guys got a good idea about the fact that ENT, we do a lot of nose picking and ear cleaning, but we also have very interesting pathologies that we're fortunate to deal with, and also many times our territory can border on the neurosurgery territories.
Hey, Aaron, thanks a lot. Great talk. Thank you very much. Great to see you. Sorry for interrupting. I'm going to go.
Oh, okay, cool. Yeah, thanks. No, thanks for tuning in.
Great. Really appreciate it.
My pleasure. No problem. So I hope you guys got a good idea about a very small area of ENT, but certainly a neat niche where we're able to work with the neurosurgeons, really understand the skull base anatomy and the sinuses that most ENTs typically don't really deal with. I'm not sure if they have questions or chats, Josh, if there's time to answer.
Yep, I can open up the chat now if you want to take a look at the questions that will then come in.
How do I do that?
So there should be the chat function.
Hold on. I got it. Okay. Wow. Okay. So
the questions come pretty quick, but just answer a few that you can get to.
All right. Okay. Got it. It goes so fast.
Yeah.
Can you go? Can you go? Oh my God.
We got 1,400 people here for you. So.
Wow. Unbelievable. Wow. That's unbelievable. All from New York. Okay. Let's see. What made me specialize in ENT? Well, my dad was actually an ENT. He's more of a general ENT. I'm not really a general. We focus more on like tumors and sinus disease, but I think it's a really cool field. There are a lot of things we do, whether it's from head and neck cancer to sinus disease to voice to inner ear. There's a wide range of things, both in office and surgical, that allow us to really form our practice the way that we want to. Let's see. Do you have to secure the flap and the collagen in the bone defect, or is tucking it enough? That was from Rohini Verma. No, the truth is the hydrostatic, things just stick in the nose. You want to get a good tuck. Again, there are a lot of ways to do this, and I'm only doing it when I was taught in fellowship. I trained in Pittsburgh, the multi-layer closure is usually the go-to. There are many ways to do multi-layer closures. More complicated defects require more tissue, more layers, different 3 dimensions of the wound you're closing. But the simplest defects really require exposing 360 degrees around it with bone, getting a layer above the bone as an inlay, and then putting something as an onlay, which it's not really secured, but we do tuck absorbable packing Surgicel, which kind of makes it stick a little bit around the periphery. And then we use some Duraseal or Tisseal or Adherus. These are different dural sealants we use in the nose. That's all absorbable stuff, and some gel foam, which is absorbable. So the absorbables we put in typically allow it to stick. Let's see. How does CSF leaks through sinus differ from CSF leaks into the spine? Can the patient, say with Chiari, have a higher likelihood of CSF through the sinus? I'm only an ENT, so I don't really deal with sinus. But yes, people can develop spontaneous CSF leaks through the sinus, through the spine. It's a very, very difficult disease to deal with because sometimes it's very hard to find the dural defect. Oftentimes they could be multiple. I definitely don't deal with that because I'm really all up, really above the clavicles is what I do. But it's the same, it can be the same process. I don't know how intracranial hypertension relates to spinal CSF leaks though. I'm sorry, I wish I could be of better help. Let's see. Just Josh, tell me when my time is over because I really have not.
5 more minutes.
Okay. You mentioned that CSF leaks are prevalent in overweight, obese females. Is there a direct correlation of obesity to CSF leakage or abnormalities? It's just something, it's a demographic. Just because you're obese doesn't mean you're going to have CSF leak. Just because you have a CSF leak doesn't mean you're obese. It's just a particular demographic that can be susceptible to something like this. For example, something called nasopharyngeal cancer. There's cancer on the back of the nose is very prevalent in Chinese people, Eskimos. That particular demographic is seen in various types of nasopharyngeal cancer, just like obese middle-aged females seem to be the demographic for these spontaneous CSF leaks due to intracranial pressure. The one I have tomorrow is actually a male, and he's not even not that big. He is middle-aged though. Let's see. How is the brain that sticks out always non-functional? Does it have some collateral side effect as it does end up pressing some other part like the flattened pituitary? Well, the knuckle of brain that usually herniates into the nose, again, I'm not a neurosurgeon, but in my experience, it's never functional. Many institutions get CT angios, which are just contrast-enhanced CT that highlight the vessels, because sometimes if you have reops, revisions, a big CSF, like big skull base defect, you can have vessels, intracranial vessels, like interpolar vessels that can herniate actually through the defect in with the brain tissue. So it's not as much as functional brain tissue you're cauterizing, it's also potentially dealing with a vascular accident, which is important. And it's important to know beforehand. Very small CSF leaks typically don't have that. But bigger ones, you really have to worry about any neurovascular structure that's there just to prevent any cerebrovascular accident. Why can't you put, I guess, mucosa over mucosa? I had mentioned that because you get something called a mucocele. The mucosa is just the wet lining of the mouth, the nose, and it has mucus glands, and it makes mucus. You want it to be exposed to the environment, the lumen of the sinuses. And if you cover that, the mucosa will continue to make mucus, but it won't be able to drain, and you get this mucocele, this ball of expansile mucus which can then press on adjacent structures almost like a balloon and can cause problems down the line. Not immediately. They can cause problems 10 years later, But the gestalt is, the dogma is mucosa always has to be stripped before putting an additional layer of mucosa over it. Or you can probably cauterize the daylights out of it. Is there any advice you'd give to high schoolers interested in joining the medical field? I mean, you gotta love what you do. That's really it. You know, you really gotta enjoy what you do. And if you're fortunate to know what you think you're gonna enjoy that young, then I just go for it. I mean, medicine, it's not what it used to be. It's not as lucrative. A lot of politics and bureaucracy in bigger places, but as long as you're honest with yourself and you really know what you want to do, you know, I think that's the best thing you can do. But also, it's important to have a meaningful personal life too. I got 4 kids at home, wife, and so those things are also, they complement each other. Let's see, maybe one or two more questions.
Yeah, let's do like one more question.
Am I German? No. That wasn't my last question. Okay, let's see.
I am, if anyone was wondering.
Let's see. When you reconstruct using layers and flaps, is there no need for microsurgical repair of the blood vessels? How is it vascularized if there's no microsurgical? Okay, so you have to understand different types of repair, okay? Microsurgical repair of blood vessels is hooking up blood vessel A to blood vessel B, like that, okay? With my case, I'm not cutting vessels. My vessel is intact and it's supplying an area of tissue. I never cut my vessel. I elevate it, attached, and then I move its supplying tissue to cover the hole. Not a free graft, but a pedicled graft. So the pedicle is my intact blood vessel. I hope that answers your question. That was it. If you have any questions, I'm at Lenox Hill Hospital in Manhattan, and I'm happy, you know, to be of any service for you if you have any further questions. I'm really happy to be there with you guys.
Thank you so much for joining us today.